start with maternity. The first part of it, or the first thing we'll talk about is we need to know how to estimate the delivery dates, okay, or the estimated date of delivery. And then for the purpose of English, we have a special way of going about it. And we are going to use the Nagel's rule to try to understand how to determine the estimated date of delivery of a pregnant woman. And this is the standard rule or the standard formula that I would want everyone here, if you have not encountered it before, or you have encountered it before, but you struggle to understand. It's very simple. It is not difficult to understand. So we looked at the Nagel's rule and then how to use it to determine or to calculate the estimated date of delivery. After that, we'll continue with other aspect of it too. So the first one, of course, after fertilization and everything, you need to know when the woman is due for delivery so that you can prepare the woman towards it as a care provider. And then the woman will also need to know so that she will prepare herself for it. And so for the purpose of English, we are going to use this special rule or this special formula for determining the date of delivery. And this goes for people with a regular menstrual cycle, which has about 28 days. And so when it comes to the English, they might not really tell you that the woman is really having a normal menstrual cycle, but for a normal person, we understand that the person should have a normal menstrual cycle. So, and all for all questions in English that I've seen, this rule works for them. So we are going to, first of all, what you need to know for this is that you have to determine the first day of the last menstrual period. That is very, very key. We all know that for a normal menstrual cycle, you have it lasting for about 5 to 7 days for a normal menstrual cycle. And so if you want to use this rule to determine someone's date of delivery, you have to note the first day of the last menstrual period, but not when the menses ended. This is where sometimes people get confused as to which of the days the person is going to use. When you are using, you don't use when the person said that she had her last menses ended. You rather pick the day that the menses started. So for instance, if we are going to use, let's say, this month, December, today is 14th, and then let's say someone menses started on let's say 7th, okay, or yeah, it started on 7th December and then ended somewhere on the 7th, ended on the 12th. That is about 5 days. Okay, 7th ended on the 12th. If you want to in the future, this woman get pregnant and comes to you and you want to determine the estimated date of delivery, what you have to do is that you have to pick the first day of the last menstrual period. That is on the 7th December. But rather, you don't go and pick when it ended, which was on the 12th. So you have to, your attention must be on the date that the menses started. Then you start your calculation from there. So let's go into how to do the calculation. So if you want to do the calculation, the rule is that you have to add 7 days to the first day of the last menstrual cycle. So let's say 5th December. When you take the 5th December, then you add 7 days to it. When you add 7 days to the 5th December or the 7th December or whichever date has been provided, you add 7 days to it. Then you count 3 months backwards. Okay, you count 3 months backwards. When you count 3 months backwards, then you add the appropriate year to it. Or another way you can also go about it is that when you are able to determine the first day of the last menstrual period, you add 7 days to it. Now, when you add 7 days to it, then you count 9 months forward. Okay, you count 9 months forward. Then you add the appropriate year to it. sometimes the difficulty when it comes to counting of months, it's also there. People tend to, when you are counting months, okay, let's say you are counting months forward. When you, if the month is in December, you go and start from January, that will be 1 month. But you see that people will start counting and they will start counting from December. When you do that, you're going to get a wrong figure. So, or you're going to get a wrong number. So when you want to count the month, you move a month or you move forward. If you are counting backwards, let's say we said that you count the months backwards, 3 months backwards. When you're coming to start counting and we are in December, you go back. So you start from November. So your first month will be in November. Then you go to October. Then you go to September. So that is how you'll be counting your months, either forward or backwards. Either way you do it, you are going to get the same answer. Or if you do it correct, you get the same month or the same answer for it. Okay. So here it says that you subtract 3 months and add 7 days to the first day of the last menstrual period. Then add 1 year if appropriate. Alternatively, you can add 7 days to the first day of the last menstrual period, and then you count 9 months forward. So let's do this together. I have a question in it that we'll do it together. I am giving this question. Okay, I am reading it. A woman comes to the maternity unit and then tells you the nurse that her first day of the last menstrual period was 13th July 2024. 13th July 2024. And then the menses started from 13th July and ended on the 18th. Determine the estimated date of delivery for this woman. The menses started on 13th, ended on 15th July. And then the question is that you are to determine the estimated date of delivery for this woman. Using what we have gone through or what I've said, let's determine the estimated date of delivery for this woman. I am waiting for our answers before I go on.
20th April 2024.
Yeah. So we haven't, people are putting answers in the chat box, okay? 20th April 2025. Are we all getting 20th April 2025? Or there's someone here who is getting a different figure? Feel free, this is an adult class. In case you don't understand anything, come up with whatever you don't understand, and then we'll be glad to help each other to understand it, okay? All right. So I can see that a lot of people are putting the 20th April, 20th April, 20th April. So that means that we've gotten the scenario I'm trying to paint.
Okay, so please, can you explain it again? Because some of us this is our first time, so.
This is your first time, okay. All right. So what I said was that, okay, so let me use the question I posed. So I said that the first date of the last menstrual period was 13th July 24. The cycle was a normal cycle, so it lasted for 5 days. So that means that from 13th to 18th, that the menses lasted for. So the cycle was between 13th to 18th July. And we are saying that if you want to determine someone's estimated date of delivery using the Nagel's rule, what you do is that you pick the first day of the last menstrual period here, which is 13th. Don't pick the last day, which is the 18th. Now, when you pick the 13th, then you add 7 days to it. So we have 13 plus 7. That gives you 20. Then we are saying that you now count 3 months backwards. Okay, so let's first count the 3 months backwards. When we finish, we now count 9 months forward. So in counting 3 months backwards, we start from July. So we move to June. The first month will be June. when you are counting backwards, it will be June. So June, then you go to May, then you go to April. Kindly mute out for us, okay? Someone is muted. We are getting a feedback here. Madam Hannah. Madam Hannah, kindly mute out for us. Thank you. So we're saying that you start from June, May, April. So April is the month that we are expecting the woman to deliver in. And then we've already gotten our 20. Then you add 1 year to it if appropriate. And at this point, we need to add 1 year to it because we are counting backwards. So instead of the 24, we're now going to get, my God, should I meet this person? Let me meet this person, okay. Okay, I've muted them. So when you count, so you're going to get 20th April 2025. Okay, so that is how they arrive at this answer. Then if you want to count 9 months forward, you still arrive at the same answer. And it's the same principle. You add 7 days to this one, which will give you the 20. And we know that we said the month is July. Then you count 9 months forward. So July, you go and start from August, September, October, November, December, January, February, March, April. Then you move into the new month, which will be, the new year, which will be 25. So this woman is expected to deliver on 20th April 2025. Does this make sense?
Yes, sir. Thank you.
All right. Okay. So that is how to use this rule to determine someone's estimated date of delivery. Very simple, not difficult. And there are a lot of questions on it. If you've been doing maternity questions from even all the Q banks, you get a case study question and they pose the question to you. And the first one is determine the estimated date of delivery. And if you know this rule, you are good to go. You just apply it and get your figure and you get your correct marks for that. So that is it. Okay, so let's move on. I think we are good with this. And the next thing we'll talk about is how to determine the gravidity and then the parity. So we have an acronym that in a question, you could have the acronym being posed to you with some numbers attached to the acronym, and you'll be asked to explain or you'll be asked to give an interpretation.
Boy. Yeah. Let's go.
Oh my God. Can I get a co-host to do this job for me? If not, my class will be interacted. So let's go to yes.
Yeah, you can use me as a co-host so that I can be
Let me do Mr. Hayford the co-host so that whoever comes on board to interact as you just meet the person for us. Mr. Hayford, kindly talk for me so that I'll get you on board then.
Hello.
Okay. Okay, you're already a co-host. All right.
Oh, okay. Thank you.
Yeah, you're already a co-host. So that's good. All right. So let's go through the gravidity and then the parity. Now, so let me just give the meaning of gravidity, which is, it talks about the number of pregnancy that one has had. Okay. The number of pregnancies that one has had, including the current pregnancy.
Hello. Hello, sir.
Yes, Nana, yes.
Yeah, please, I'm getting a little confused. Please, assuming you with the formula.
Okay.
The formula that you have to add 3 months and then you add 7 days to it. Plus,
you don't add 3 months.
No, you subtract 3 months backwards. Then you add 7 days to the date. Then you add 1 year to it.
You just change the
Assuming
year. If it is 23, you do it 24. So it's just the year you change.
okay. So assuming the person LMP is in January.
January,
So
which
let's
January.
say
Give us a specific date.
9th January.
9th January. Year.
9th
That's a
January.
year.
If you subtract the 3 months backwards, then it means you are going to get December, November. You are going to get like October.
Yes,
Yes.
please.
Plus the 7 days. If you
So,
add 1 year to it, then it means you are going to get more than 1 year.
no. So that is why. So your 9th January you gave us. Which year do you want us to use it for the calculation so that you understand it well? Give us a year.
Let's say 2025. Okay, we are in 2024, so let me use the 2024.
2024.
Yes.
So you want us to use this, right? Okay, so Nana
Yes.
wants us to use. Nana is getting a bit confused. So class, let us all help her to understand this for us. Okay, so we are saying that she has given us someone's last menstrual period. Okay, that the first day of the last menstrual period was 9th January 2024. So what we are saying is that if you want to determine the estimated date of delivery for this person, what you have to do is that, Nana, you add 7 to the 9. What do you get? Nana, let's do it together.
Okay, 9,
9 plus 7, this is 16.
Yeah.
You get 16, right? So
January.
the 16 is established. Now, what you now do is that she's saying January. So January,
November, October.
you count 9 months back, 3 months backwards, you get the October. So October is 10, right? The 10th month.
Then the year will be
Then we are saying that Nana, you don't add like 1 year. It's just the year. If it is 24, you add like 1 to it to 25. So you get this 25.
Okay. You just add 1. Oh, okay, not it. Okay. I get it now. Thank you.
Does it make sense, Nana?
Yes.
It's
Thank
okay.
you.
Please, I have a question.
Okay.
And so like this patient, the Nana example that Nana gave, it's presume that any woman who gets pregnant takes like 9 months for the pregnant, like for the woman to give birth, like the expected date of delivery.
Is it confusing?
Say yes,
No,
9
but
to 10 months. So if the patient
January, February, March, April, May, June, July, August, September, October.
I'm not getting Madam Raquel. Raquel, I'm not getting you.
Her network is bad.
Raquel's network is bad.
Please, I'm also confused. Can I continue?
Yes, I'm also getting confused. Don't worry. I'm also getting
9th
confused.
January.
So
Then
that
it
means
means
that
that
she's going to get
the
pregnant more
person
than
I'm
1
will
also
year.
give
getting,
birth in that same.
wait, okay. Let's do it together again. Okay. So that means we've even passed 1 year. Is that the case? All right. So Nana is saying that someone's first date of the Mary, your hand is up. Madam Raquel, we are not getting you. If you can reposition yourself again, you come back again. Mary,
Yes.
you want to come in? Yeah.
Yes, please. You know, this rule, what I
Uh-huh.
was told was that when you are doing the calculations, let's say you are adding the +9 to the MEMS. When you add, you realize, every a year is made up of 12 months. So let's say I've added the 9 to the MEMS and I've had 15. 15, I know that the year is always 12 months. So I'll deduct 12 from 15, meaning I'm getting 3. And the 3 will be the match. That's match of that month. A match, the men the client will deliver. Then the 12 that I've subtracted, that one becomes the year that I'll add to the year coming to take place. But once you get, and the months are not more than 12, there's no need adding to the year. So let's say, as Nana said, January.
Okay.
If, as Nana said, it's January. When I have,
Okay.
she gave what? Is it 9 for what?
9, yeah. She
9,
gave
9.
9 January. Okay.
Yes, 9 January. From January to December, a client should be able to deliver because it's within that same year.
Okay.
It's within that same year. So with 9, when I add 7 to 9, it will give me 16. Then
Okay.
plus 9, it means they're taking me to October. So once there was no
October.
remainder out of the month, then meaning that I'm still in the 2024 to deliver.
Okay, 2024.
Yes, please. So when it is,
So,
it's safe to add with the 9. If you add with the 9, it will always help you to know that as the number is more than 12, I'll have to deduct 12 from the number. When I deduct 12 from the number, the remaining answer, let's say 12, the answer minus 12. What answer I get is the month. Then the 12 that I deducted is a year. So it must go and carry, it must be +1 to the year that the client is currently in. But if there's no additional year deduction, then the month maintain. I don't know whether you've understood me. Hello.
confused now.
Hello.
Why people are confusing me?
Yeah, so me, I'm getting confused.
It's a lot. It's a
Yeah,
lot.
I'm
yeah,
saying
please,
that
the one
Wait,
you,
okay.
the
Wait.
first
I'm
explanation you gave is, I think it was best, because right now I'm getting confused.
Okay, wait. So let's take this, okay. Let us take this one. Let's take the counting of that 9 months forward and see what we'll get for Nana's question. Okay. Those of you whose sons are up, okay, I'll call you. Augustina, I'll call you, okay. Wait for me, okay. So Nana gave us 9, okay, January 24. Now I realized that when we added the year to it, after getting the months, or after getting the date and the month, when you add the year, it's as if it was more than, I mean, even more than 12 months. So that which was not normal. So when you take the 9, then you add 7 to it, you're getting 16. And then we are saying that January. So let's say you are adding 9 months to it, means that you're going to get October. Okay, 16th October. Then because this one, so you see, this thing was saying that add 1 year to it, if appropriate. So in this instant, Nana, you're not going to add 1 year to it again. You maintain the 24 because so it is still the same when you count the 3 months backwards. So if you count 3 months backwards, you are not going to add 1 year to it. So it's not all the time that you add the 1 year to it. Okay. So when you count 3 months backward, you still get your 16. Then you get your October.
please,
And
can I come?
you maintain the 24. Because when you add 1 year to it, you are going to get a wrong figure or you're going to get a wrong date. So let me go back to my notes so that you.
Please, can I come in small? You know the -3 MEMS that you're using as you minus the 3, it went back to the following year. Let's say 2023 that it went back.
So that is why I'm saying that. I'm coming.
Yes,
I'm coming.
you are still applying your rule as
Madam Mary,
+1.
Madam Mary, Madam Mary, Madam Mary.
Yes.
Madam Mary, wait for me, okay? Wait for me. So initially when I was saying, I said that you add So if you look at my notes here, I'm saying that it is here. Then add 1 year if appropriate. So it is not all the time. Even if you count 9 months forward or you count 3 months backwards, it is not all the time that you have to add the 1 year if you have to add the 1 year. So what you have to determine is the first day of the last menstrual period. Listen to me. What you have to determine is the first day of the last menstrual period. Add the 7 days to it. Now, you can decide to count 9 months forward or you count 9 months backwards. Sorry, 3 months backwards. Now, when you finish, now come and look at the year or when the last menstrual cycle started or when it says it started. Is it appropriate for you to add 1 year to it or you have to maintain the year? So this is the simple way you can understand it. And so in Nana's instance, you don't need to add 1 year to it. For the month, for the date and the month, we all agree that it's going to be 16 and then it's going to be in October that the woman will be expected to deliver. But at first, I added, 1 year to it and I had 25. And then I realized that, no, 25 will not be appropriate. So, and then I realized that in my notes, I even stated that you have to look at it if it will be appropriate for you to add 1 year to it. So in this instance, you are not going to add the 1 year to it. Where you're going to you add the 1 year is like the example I gave first, where you have the what is it? The July. So in July, you realize that in July you enter a new year. Okay. So if you are going to enter a new year, that is where you add the 1 year to it. So the same thing, if this to be happening, let's say she gave a date, let's say 7th, let's say February. Okay. She gave 7th February, and then we have to use 7th February. You realize that if you are using months like January, February, and I think what is it? March, you might not, or you will not add the 1 year to it. You might have to maintain that year in which the question has been given, or you have to maintain the year. I don't know if this settles the whole argument here.
Yes.
Nana, does it now settles the argument here?
Yes. Yes.
Okay.
Thank
So
you.
you have to, yes, so you have to look at the month in which the date has occurred. Then you have to now ask yourself, is it appropriate to add the 1 year to it or not? For the counting, either 9 months forward or 3 months backwards, you arrive at the same date and then the month. But the issue has to do with whether the year will change or the year will not change. So you would have to now determine that by looking at the year that or the month in which the woman had her last menstrual cycle. Yes, I still have 2 hands up. Let me see this. Augustina, yes, you can come in.
Hello.
Yes, Madam
Hello.
Augustina. Yes, Madam Augustina.
Basically, looking at this, the scenario that Nana gave,
Yes.
why don't we go with one rule by using the add 7 days and you add on, you move forward, you count 9 months forward. I think that's the most easiest.
That is
Looking at the
if that is what works best for you, that is fine.
yeah,
If that is what works best for you without confusion, that is fine.
yeah. But
Yes,
looking
hello,
at it, when they give you beginning of the month,
Let's Augustina finish, okay? So that we'll do it one after the other, okay?
if like let's say the woman's menstrual cycle is at the beginning of the year,
The year,
there's
fine, yeah.
going to be much confusion with
Much confusion.
adding. So why don't we go with just one alternative?
One rule, okay. So
Yeah.
in other instances, the first rule, subtracting the 3 months will also work. That is why
Basically it will work for those who really understand it. But for
yes.
someone who will struggle, I would advise that she goes with the second rule. Thank you.
Okay. So Nana, sorry, Madam Augustina is suggesting that in order to prevent, confusion, we should stick to adding 7 days and adding 9 months to it, and then we are good to go.
I'm a 10.
Okay. All right. Madam, Mr. Shafiu, your hand was also. Yes.
Hello.
Yes, Shafiu, go ahead.
Is with the first formula, subtracting 3 months backwards and adding the following year and
Yes.
adding a year. You see, when you did that from the January, when you add the 3 months, it will send you to October the previous year, which will be 2023. So when you add a year to it, then it will be 2024.
2024.
So it means that formula still also holds.
Still works.
Those who
Still
are
works. Okay.
Yeah.
Still works if you are moving the year backwards too. Is that not your case?
Yeah.
Yes.
Okay.
It
Okay.
works.
Okay. So it will still work if you are moving the year
when
backwards.
you now go 3 months backwards, it will send you to 2023.
Okay. Okay.
So
okay.
that you add a year to it, which will now bring you back to 2024.
Back to the 24. Okay. That is also someone's point as well. Okay. Thank you, Mr. Shafiu.
You have to make the choice.
Madam Mary, was it Madam?
You are comfortable with, then
that's the same thing I wanted to actually tell you that when you do the mathematics,
you wanted to say the same thing, Madam Mary.
Yeah, because the month was coming back to the following year.
The following year, okay.
So before the year in which we are, let's say 2023. So if you're in 2023 and you are still adding your 1 year, it wouldn't. If somebody's math is no good, the best is plus 7 plus 9. Then you are fine to go.
Okay.
I think that's fine.
All right. Kabiru. Kabiru will be the last person. Then we move on. Okay.
Yes, I even want to put down my hand because I was also coming from the same angle that the 1 year plus is constant.
Okay.
Because when you subtract the 3 months from the current month, it's definitely
will send you to.
Yeah. It will send you backwards to the previous year.
It will send you to the backwards in terms of the year.
Backwards, yes, yeah, in terms of the year.
Okay.
So it's constant.
Okay, that's okay. All right. Thank you all for bringing in your suggestion.
Now, please. I want to put down my hand. How that put?
Oh, you just go back to. I mean, you just click on. I think you have to click on your name again and then. All right.
Obviously, people went home.
So let us unmute up, okay?
All that. I'm loving the participation. I'm loving the engagement. I'm loving the information. It's amazing.
Okay, so we've settled this issue. No issue again with regards to this. Okay. All right, let's go on. So I was trying to explain the gravidity, the parity. Okay. In this abbreviation I'll be using, I might not talk a lot about this parity here. Okay, but the gravidity might come up. So the last time when I was doing this in a different class, the person was telling me that she made a question where the question was on only, I think, the gravidity and the parity, and the person says that she was confused. Now, so the basic interpretation or the basic meaning of gravidity is that the number of pregnancies that one has had, including the current pregnancy. So if you want to determine the gravidity of a woman, you have to ask the woman to see as to whether the person is currently pregnant. And so if you determine that the person is pregnant, when you want to determine the gravidity, you now add the current pregnancy to it. Or in your questions, when you meet any question asking about, gravidity, and then they say that the woman is currently pregnant, when you are counting the number of pregnancies that the person has had, you have to add the current pregnancy to it. If not, if you take the current pregnancy to you might be confused or you might get a wrong figure for the gravidity. So the gravidity determines it stands for the number of pregnancies that an individual has had, including the present one. Now, when you talk about parity is like the number of deliveries that one has had, whether they are living, whether they are dead, or whether, so it tells you the number of deliveries that one has had, okay, whether they are living or they are dead. So gravidity and parity, that is the meaning. Now, in this abbreviation or in this acronym that we're coming to use, and I know some of you might have come across it several times whilst doing your questions. We have the GTPAL, where the G stands for gravidity, the T stands for term gestation. Then we have P stands for preterm. Remember, this P here is not parity. In other books, you might see the P to be 2. So in that instance, you have parity here, and then you still have the preterm there. But for the purpose of today's class, I didn't include the parity. So the P in this acronym stands for preterm labor or preterm delivery. And we will look at what forms a preterm. Then we have the A being abortion. Then we also determine at what gestation in America do we say that someone has had an abortion, or if labor occurs. Yes.
Please, can you come again with the differences so that I didn't get it?
Okay. So I'm saying that you could have in other books or in other based on the question you might get, they might add the piece might be 2. Okay. And then 1 will be for parity. And I said that parity is the total number of deliveries that an individual has had or a woman has had. Then here, I did not include all where I picked the resource I picked this from. The parity wasn't part. Okay, they only brought the preterm aspect. So most of the questions they don't really include the parity part. Okay, they only bring the preterm. So that is why I didn't include it here. But in case you go and meet a question and you are having 2 P's in it, one is for preterm, one is for parity. And then I said parity stands for the total number of pregnancies, total number of births that the woman has given birth to, or children that the woman has given birth to them. A stands for abortion, and then L stands for the number of children who are still living. Okay, because the woman can give birth and then some of them will die along the line. And so L stands for the number of children who are currently living. So we'll go through them one after the other. I've already explained what G stands for. And so you could have a question. I have a question just after this. We'll go through that question. Where you have G stands for the number of pregnancies. And I've said that when you are counting, you add the current pregnancy to it. T stands for term gestation. And then in the US or in America, any pregnancy beyond 36 weeks plus 6 days, any pregnancy carried beyond 36 days plus 6 days is termed as a term gestation. So from 37 upwards, okay, any delivery that occurs after 37 is termed as a term gestation. Then we have preterm, and then preterm is any delivery that occurs before 20th weeks of gestation. That is abortion rather. Preterm is between 20 and then 37. Preterm is between 20 and 37 weeks. So any birth that occurs between 20 weeks and then 37 weeks, it is termed as preterm. And then in the question, it was specified as whether the woman has had a preterm delivery before, and then you'll be able to interpret it very well. So we also have abortion. So abortion or miscarriage is where any delivery that occurs before 20th weeks of gestation, any delivery occurring before 20th week is termed as abortion or miscarriage for the purpose of NCLEX. Okay, let's stick to the 20 weeks of gestation. Anything less than 20 or anything before 20 is termed as abortion or miscarriage. Then we have the living. So the living, I said, or the L stands for the number of children who are currently living. And then it is only this point where you divide the number. So for instance, if a woman had, let's say, a twin gestation and then delivers all the children, and then the two of them are there, or they are, quadruple, and they are, or triplets, and they are still there, what you do is that if you want to count the number of children who are living, you split them and count them individually. Okay. But when it comes to, the gravidity, when it comes to term, when it comes to preterm, when it comes to abortion, you count them as a whole, or you count them as one. So let's say someone give birth, and then there was, it was let's say a twin gestation, so there are two. During the term gestation, or during gravidity, you count it as one. But when you come to the living, you split the twin gestation, or you split the twin, and then you count them as two. So at that point, that is when you get the L being more than the G or the T or the P, or whatever it is. But you will not get the G also. So you might get G also being more than the L, if you have death occurring as well too. So I am saying that you only split the children when you have twin gestation, or multiple gestation occurring, and then they've all been delivered and they are living. When you are counting the living, you split them and count them individually and add and sum them up. Now, when it comes to the gravidity, when it comes to term or preterm, you don't split multiple gestation, or you don't split twin gestation. Does this make sense to us all? We'll take a question and go through together. Okay. Hello.
Hello, please. With abortion, I saw 28 days somewhere. 28 weeks. Yeah.
From which resources?
8. From the woman with the wedding weight.
The woman with the wedding.
In the video.
She said abortion is 28.
Yeah, 28.
Are you sure? I have to go and look at it again. Okay,
please,
so
please, it's less than 28, rather, not 28. You can deliver, if you deliver 20, exactly 28, that one becomes preterm. But
yes,
less than 28, it makes it the abortions.
No,
we can also,
no.
Because back as
Hello. Let me make
28.
this clear to us. So for the purpose of the English, if the woman said it is anything less than 28 is abortion, it was a mistake. I beg you. Okay.
Okay.
If the woman said that anything less than 28 is abortion, then it was a mistake.
Okay.
For the purpose of the English, I beg you all.
Okay.
For the purpose of English, it is 20. I beg you.
Okay. Thank you.
All right. Okay. So let's move on. Yes, Prila, your hand is up.
Yes, please, can you come again with splitting of when to split the twins?
Okay, so I said that you only split, you only split and count when in case the woman had any multiple gestation. It could be, twin, it could be quadruple, it could be triplet. And so in that instance, when a woman let's say had a twin gestation, delivered them, they are all living. When you get to the L aspect, or the living aspect, you split the children. If they are two, you split them into two. If it's a twin gestation, split them into two and count them. So in that instance, you are going to get two children who are living. If it was a triplet, you split the three and then count them individually. So in that instance, you're going to get three children who are living. You are not going to get one. But if it is about term, if all of them, if the pregnancy was carried to term, and it was like a multiple, pregnancy or a multiple gestation, what you do is that you count it as one at the term session, you count it as one. But when you get to the living aspect, you split the children into three. And then if it is, triplets, and you count them as three living.
Okay, thank you.
All right. And next, yes. Yeah, Annette, you can unmute
Hello.
yourself. Yeah, Madam Annette, you can go on.
Hello.
Yeah, hello.
Yeah, Madam Annette, go on. Go on, I can hear you.
Hello. Yeah, please. I'm not a midwife anyway, but I just want to understand what you are teaching. You said
Okay, sure.
gravity. You said gravidity is like the number of pregnancies that you have carried, and then
Yes.
parity is like the number of children you have. So um with the last explanation that you are giving, that gravidity, if the person comes with multiple pregnancy, you count it as one.
Yes.
Will you say that let's say if the person had carried pregnancy just one but has twins, are you right to say it's gravida 1 para 2?
Gravida 1 para 2.
Para 2.
So you said that the person had how many pregnancies?
Just one, but the person carried twins.
So at the moment, the person is carrying twins.
Yes.
And then
At the moment, no. At the moment, the person is not. Okay. So let's say that if at the moment the person is carrying just one, will you say
and then
that two? Yes, that two para 2.
No. So if the person is carrying,
the first pregnancy was twins, but the second one is just one.
Wait, Madam Annette, wait. In total, how many pregnancies the person has had, including the current
Let's
one?
say
How many?
2.
2.
Yes, including the current one.
The current one.
But the first pregnancy, the woman has 2 children out of the first.
Okay, no.
Yes,
the parity
twins.
will still be 1.
Oh, okay.
So it will be gravida 2 para 1.
Mm-hmm. Oh,
Then
okay.
when it comes to, if you are talking about the living, then the living will become 2.
Okay.
Because I mean, the first pregnancy was twin gestation, and then all of them was delivered and they are living. So during the living, you split the twin gestation and then you count them individually. So you're going to get living to be 2. But the para, because the para is the total number of deliveries a person has had, it will be para 1.
Okay. Okay. Thank you.
You're welcome. Yes. Any other question? Or any other inputs, clarification, whatever it is, bring it on board. Okay.
Hello, can I?
Yes.
From my understanding, I think the preterm is 20 to 36 plus 6.
Yes.
Is that right?
Yes, please.
20 to 36 plus 6.
Yes, please.
Okay, thank you.
Yeah. Okay, so I saw a question in the comment section. The person is saying that, what about twin and one is dead? Yes, you subtract the one that is dead. So you count it as 1, that because 1 is living. So the L will be 1. The living is the number of children who are living. So if the person had twin gestation and then, deliver them and 1 is normal, you only pick the one that is living and then put it there. So, Abdurrahman, that is the response to your question in the comment section. Okay. All right. Then let's briefly go through this together. Very simple. And then I know that most of us know this. And it's one of the areas that if you know and you go to the NCLEX and it beats you, I know it will pain you a lot. Because you go and get a case study question on maternity, and then they are asking you about the various classifications of the signs of pregnancy, and you are sitting there, you don't know where amenorrhea will fall within, and you are struggling, and you'll be like, is it presumptive? Is it positive sign? Is it probable sign? And you are there and you are struggling. So my kid will tell you that if you're a student of NCLEX, know what everybody knows. And then this is one of the areas that I believe that if anyone is preparing for NCLEX, the person will know. And so when it comes to the classification, you need to know which sign will fall under what sign or what class. So we'll go through it briefly. and then we'll see where we'll be able to end. So we are doing presumptive sign, and then this science comes about due to the hormonal changes that takes place during pregnancy. Some of them will be as a result of some physical changes that will take place during pregnancy. And the first part we'll talk about is the presumptive. Hello, mute out for us. The presumptive signs will deal with things that other factors. Okay, so the probable signs and the presumptive signs, they are things that you can have other conditions also contributing to them. So it is not only in pregnancy that you can have the woman exhibiting the signs. And so, for instance, if it is about amenorrhea, you can have other factors that can lead to what we call amenorrhea, or for a woman to experience amenorrhea. A classical example is if the woman is in her menopausal stage. When a woman is in menopause, I mean, we know that their menstrual cycle gets disrupted, and so they will tend to experience amenorrhea. You could have even other medical conditions that can influence a woman to go into amenorrhea. The same thing applies to nausea and vomiting. We have several 1,001 medical conditions or factors that could lead to someone experiencing nausea and vomiting. So these are things that the woman will also tell you that I am experiencing this, I am experiencing that. Okay, so for the purpose of NCLEX, these are basically some of the presumptive signs that we all need to know. The first one being amenorrhea, which has to do with the stoppage of the menstrual flow during pregnancy, which resumes after delivery. So amenorrhea is one. Then you talk about nausea and vomiting. We'll go much more into nausea and vomiting. We talk about excessive vomiting, and we looked at some of the things we need to do for the woman during this period. And we know that nausea and vomiting will happen due to the hormonal changes that takes place during pregnancy. You also have the breast tenderness, tingling, and all other things that will happen to the breast during pregnancy, just to prepare what we call the breast milk production, and then prepare the woman for breastfeeding as well too. Then we have urinary frequency. And so urinary frequency in pregnancy mostly happens during the first trimester and then the third trimester. The first trimester, because of what? Because of hormonal changes. That is what plays a role in the frequency of urination in pregnancy, or the urinary frequency. Then in the third trimester, why would a woman experience what we call urinary frequency? It is simply because the weight of the uterus will exert pressure on the bladder. And so any little time the woman will tell you, I want to go and free myself, simply because of the weight of the uterus that will exert its pressure on the bladder. And so there is urinary frequency. Then there is also quickening. We all know that quickening talks about the fetal movement, or when the woman starts to experience the movement of the fetus. Now, we are nurses or midwives, and so we also know that someone can come to the hospital and tell you that I am experiencing some form of movement in my abdomen, and they might even think that it is pregnancy that they are having. Okay, and so quickening is not only related to pregnancy, but that is why you cannot base on it and say that because someone is experiencing or is giving you a complaint of quickening, you will conclude that it is pregnancy the person is carrying. Now, if it is pregnancy, the woman would need to understand when quickening starts, so that in case they tell you that I am around this week of gestation and then I have not experienced quickening, as a nurse or as a healthcare provider, what will be your response to that woman? And for the purpose of NCLEX, what we should know is that for quickening to begin, or quickening begins between 16 weeks to 20th weeks of gestation. That is the period, the duration at which we expect a woman to experience quickening. And I've said that quickening is the movement of the fetus, or fetal movement, that the woman will tell you that they are experiencing, or they are having the moving of the baby. Now, we have the week that for a multiparous woman, when they say a multiparous, someone who has had multiple pregnancies before. Yeah, so for someone who has had multiple pregnancies, they tend to have early quickening, or they tend to experience early quickening. However, for someone who is having her first pregnancy, that is someone who is having a first pregnancy, they do not experience the quickening early. And so, like I said, quickening is between 16 to 20 weeks of gestation. So if a woman comes to you and say that around 18 weeks of gestation, the person hasn't had quickening and they are worried about it, what will be your response to the woman? You need to educate the woman that quickening is between 16 to 20 weeks of gestation. And so the woman is still within the time duration by which quickening is supposed to happen. So they shouldn't worry. It is only after 20th weeks of gestation that if a woman who is pregnant and hasn't had quickening or hasn't had a feel of the movement of the baby or the fetus, that is when you ask the woman to come for proper assessment to be done. And like I said, for those who have had multiple pregnancies before, they tend to experience quickening early. So they will experience quickening around 16 weeks of gestation to 17, between that time duration. And then those who are having their first pregnancy, they will experience it a bit late, around 20th weeks. So like I said, it's only after 20th weeks that if a woman has not had the quickening or has not had a feel of the baby moving, then you ask the woman to come back for proper assessment to be done, and then assessment to be done to determine the well-being of the uterus, sorry, of the fetus. So it says that the first perception of fetal movement by the pregnant individual may occur at 16 to 20 weeks of gestation. Every pregnancy is unique, and quickening could happen earlier or later. So this is the meaning of what I just said. So if you have a question on quickening, you can bring it on board as you want to. Then we have fatigue. I mean, as some form of body changing taking place, you experience fatigue. Then we also have changes that will take place, some skin pigmentation that will take place, such as the linea nigra and melasma. So these are what we call the presumptive signs of pregnancy, that if you are here, you need to put this one at the back of your mind. And then whenever you meet this in your questions, don't think about it. Don't stay long on it. Just give it to them and then get all your score for it. If you have a question, you have any input you want to make on this, you can bring it on board as well too. All right. Let's talk about the probable sign. So the probable signs, yes, first test iPhone.
Please, sorry, I left you, but with the urinary frequency, will it increase or decrease?
Urinary frequency.
Yeah.
The thing is urinary frequency. So how does what urinary frequency?
As in, if the person will tend to urinate more often, or like they won't pee most of the time.
They'll pee more frequently.
Oh, okay.
Yeah.
Thank you.
You're welcome. And so you see what the weeks I told you, or the when I said that a woman will experience the urinary frequency, I made mention of the first trimester and the third trimester. Okay. So it means that practically you don't expect a woman in the second trimester to experience urinary frequency like that. So if a woman comes to you in the second trimester experiencing urinary frequency, one of the main things that could be causing is UTI. So you need to, question the woman more and do your, assessment in the second trimester if the woman is experiencing urinary frequency. It means that it could be UTI that is causing it. So the healthcare provider would need to do what we call urinalysis to determine if there is any UTI that is leading to it. So you have to know the various trimesters and what happens in the various trimesters, so you can advise the woman as well on it. So let's go into probable sign. So our probable signs is also not conclusive that a woman is pregnant. And then the most of the probable signs comes about as a result of the developing fetus. So as the fetus develop, we know that where the fetus is lying, I mean, there has to be some form of structural changes so that, I mean, the uterus can accommodate what we call the growing fetus as well too. So most of these probable signs comes about as a result of the growing fetus, so that there will be some form of structural changes to accommodate the fetus. And the first one is the enlargement of the uterus. So uterine enlargement, of course, as the, like I said, as the fetus develops or continues to grow, you don't expect the size of the uterus to stay the same. It has to also enlarge so that it can accommodate the uterus. Then you have the Higgs sign, the Goodell sign, the Chadwick sign. Now, we all need to know the meaning of these three signs so that sometimes they won't just give you the sign, they will describe the sign for you and then ask you which sign is being, described or explained in the question. So Higgs sign has to do with the compressibility and softening of the lower uterine segment. Okay. And this, you can only elicit this during your assessment. Okay. During assessment, when you are able to, when there is softening and compressibility of the lower uterine segment, you know that you have elicited for what we call Higgs sign. And this occurs, the week at which it occurs is also very important. We all need to know that it will occur at around the 6th week of gestation. That is when you can elicit for what we call Higgs sign upon your assessment. Then you also have the Goodell sign, which will be the softening of the cervix. Okay, so one is softening of the lower uterine segment. Then one is softening of the cervix. That will occur at the beginning of the second month. And at the beginning of the second month will be around 8 weeks of gestation. Then we have the Chadwick sign, which is a violet discoloration or a violet coloration of the mucous membrane of the cervix, the vagina, and that of the vulva. And this occurs around the 6th week of gestation. So we have one which talks about softening of the lower uterine segment, which is the Higgs sign. We also have the Goodell sign, which is softening of the cervix. Then we have the violet coloration of the cervix, the vagina, and the vulva, which is also the Chadwick sign. Then we have Bartholomew's, which is a rebound of the fetus against the examiner's fingers during palpation. And so this, you can also elicit this when you do your palpation. You have Braxton-Hicks contractions, which are irregular menstrual, painful contractions that may occur intermittently throughout pregnancy. And so when you look at what we call true signs and then false signs of labor, you understand that, Braxton-Hicks contraction is one of them because it is a false sign, a false labor sign. It's the woman will tell you that you are having some form of contraction throughout the pregnancy, and it will come intermittently. It will be, painless in nature. It will lead to no cervical dilatation. The woman will just have this form of, contractions throughout pregnancy, and it can occur at any time during pregnancy. So when a woman comes to you with such complaints, you have to understand that it is normal, and then it happens during pregnancy. So you just tell the woman to go back, and then you give them some form of maybe comfort measures they can do for this purpose. Then we have the positive pregnancy sign. And so you have to understand that positive pregnancy sign is not a positive sign of pregnancy. Okay, especially if it is HCG, that is a human chorionic gonadotropin level, that during when you do your normal UPT test, it is the human, chorionic gonadotropin level that you are determining. And if you pick it in urine, okay, it becomes positive. And it could be that it is pregnancy. It could also be that it's not pregnancy, because we have several other factors that could lead to a woman, having the HCG level going up and then excreting it in urine. So it is not conclusive that if you pick the HCG level or you do your UPT and then you pick the HCG, you don't base on it and say that this person is definitely pregnant. That is why when the healthcare provider do the UPT and then they pick what we call the HCG, they will ask the woman to go and do further test, or they will go and do either an ultrasound, which is conclusive. And it is only the ultrasound that will tell the healthcare provider that yes, indeed, the woman is pregnant. So understand that if a woman goes to do a pregnancy test and it comes out to be positive, it falls under probable sign, but it is not a positive sign of pregnancy. All right. So these are the probable signs that we all need to know. The positive signs are 3. We have you being able to detect the fetal heart rate, then active fetal movements palpated by the examiner, then an outline of the fetus on either an ultrasound or on a radiography. So if you're able to pick these things up, then it means that these are conclusive and tells you that yes, indeed, the woman is pregnant. So let's go into the first one. That is detecting the fetal heart rate. Detecting fetal heart rate, you can use 2 things to detect the fetal heart rate. Either you are using the Doppler, which is the electronic device to detect the fetal heart rate, or you can use the non-electronic device, that is the fetoscope. Now, when it comes to the Doppler, the use of the electronic device, you can pick the fetal heart rate at 10 to 12 weeks of gestation. That is the week duration that you should be able to use the Doppler or the electronic device to pick the fetal heart rate. Now, let me go a bit into this. In the NCLEX or some of the questions or some of the Q banks, they will tell you that when you are reading your question and the question asks you, the question can be at what gestation should you first use the electronic device or the Doppler to try to assess for the fetal heart rate. And then the question can be at what gestation should you assess for the fetal heart rate using the Doppler. Then the question can be at what gestation should you be able to use the Doppler to assess for the fetal heart rate. I've given you 3 scenarios here. Now, the first scenario I gave is that at what gestation should you first assess for the fetal heart rate using a Doppler? And then the response to that is that if you are using an electronic device, you should first use the Doppler at 8 weeks of gestation, because that is the time that the pacemaker of the heart of the fetus is being developed. And so the moment the pacemaker is developed, you can pick the fetal heart rate. So you should first use the Doppler or the electronic device at 8 weeks of gestation. That is when you should first use it. Then when you should probably assess for it will be at the 10th week, because at the 10th week you can pick it or you might not be able to pick it. The same thing applies to the 8th week. 8th week you can pick it, you might not be able to pick it. But when it gets to the 12th week, you should be able to use the Doppler to pick the fetal heart rate at 12 weeks of gestation. If from 12 weeks going, you are not being able to use the electronic device to determine the fetal heart rate, then it means that there is some form of congenital abnormality that is being developed, or the heart might, the fetus might be probably developing some form of, congenital heart condition. Then your non-electronic, which is the fetoscope, you use it at around the 20 or at 20 weeks of gestation. That is when, so anything less than 20, you will not be able to use the fetoscope to determine the fetal heart rate. So fetoscope is from 20 going. That is when you can use the fetoscope. Then your active palpation or active fetal movement palpable by the examiner. And so it is only the examiner who can determine that. And so if the healthcare provider during, palpation is able to palpate the various, path of the fetus or active movement of the fetus, then it tells you that this is actually pregnancy and it is a positive sign of pregnancy. And then we have the using what we call an ultrasound or ultrasonography or a radiography to determine the status of the fetus, okay, or the outline of the fetus. And we all know that if you are pregnant, the healthcare provider will tell you to go and do ultrasound so that they will be sure that it is actually pregnant and not any other thing that is causing you to have such feeling or experiencing such kind of symptoms. So these are the three positive signs, and they are all diagnostic in nature. They are all diagnosed. That is why I said that this gives you conclusive that these things are true signs of pregnancy. At this point, this is where I will end with the various, the classification in terms of the signs of pregnancy and the first part of my class for maternity. Then we go through one or two selected questions on some of the things we've gone through so far. Then we move on. However, if you have anything you want to say, or any question, any input, any suggestion, you can bring it on board before I move into my questions.
Hello, Amingo.
Yes, madam.
Yes, I would also add that the ultrasound can also pick the fetal heart rate at early stage.
Okay.
Because usually after the urine pregnancy test, the next thing to do is the ultrasound. So it's not only the fetal outline, but it can pick the heart rate at early stage,
Okay.
even before the
Okay.
Doppler.
Okay. All right. Thank you. Thank you for the inputs. Is there anyone with any? Yes, Mary. Yeah, Madam Mary, go ahead.
So, I said it seems I came across the ultrasound. It's like around 6 weeks it can pick it up. It seems it
6
was
weeks.
a
6 weeks, you can pick it up.
yes.
Is it practical?
They
Or you say you
said
met it in question? Is it in question you met it?
the ultrasound picks it faster than that of the ultrasound. So at 6 weeks coming, it can see to be able to pick up the
Okay.
heart rate.
Okay. Okay. Thank you all. All right. All right. Yes. Is there anyone with any other inputs? Okay. Let's go through this together. Okay. If you want to.
Hello.
MTS. Hello.
Okay, please, can I ask this? Normally, the presumptive and then the probable sign have been confusing me most of the time.
Okay.
Can I ask if the presumptive sign are what the woman can tell you or what she has seen herself, and then the probable can be what the the nurse or the midwife can see or somebody can see. Can I take it away?
Yeah, you can take it like that. Yeah, I think that also makes sense.
Okay.
Yeah,
Thank
because all the probable signs, you have to do assessments before you can assess them. But when it comes to the presumptive, the woman would have to tell you that for the past maybe 3 months, I've not had my menses. You'll not be able to visibly see that someone hasn't had her menses unless the person voices it out to you.
Okay. Thank you.
All right. Okay, so we have a question on the screen. It says that the nurse is performing an assessment on a client who suspects being pregnant and is checking the clients for probable signs of pregnancy. The nurse would assess for which probable signs of pregnancy is such as we have Bartholomew, we have Chadwick sign, we have uterine enlargement, we have positive pregnancy sign, we have the fetal heart rate detected by a non-electronic device. We have an outline of the fetus via or ultrasonography. This is very simple. We just went through this together. So I believe that anyone here should be able to attend this without difficulty. All right. Okay. All right. Someone should speak for us. Okay. I want someone to speak for us.
Hello.
Yes, madam, go ahead.
The nurse is performing an assessment on the client who suspects being pregnant and is checking the client for probable signs of pregnancy. The nurse would assess for which probable signs of pregnancy. Select all that apply. 1. Ballotment. 2. Chadwick sign. 3. Uterine enlargement. 4. Positive pregnancy test. 5. Fetal heart rate detected by non-electronic devices. 6. Outline of fetus via radiography or ultrasonography. So this one, they are talking of the probable signs. I think they are the signs that you, the examiner, will be able to see and see that the client is pregnant. So ballotment, yes, you, the examiner, will be able to do that one. Feel the fetal movement. Chadwick sign is through examination that you see it. Uterine enlargement.
Probable, presumptive.
Okay. Then number 4, positive pregnancy test.
Okay.
Is it presumptive or probable? We are all answering. Or I'm the one answering for you. Positive pregnancy test. That's a probable sign, or
Yeah, it is.
Okay.
then fetal heart
Yes,
rate
it
detected
is.
by yeah, because you examine the woman. Outline of fetus via radiography or ultrasonography.
So
Those are
so
positive signs. The last two are positive
they are
signs.
saying that the last two are positive signs.
It's 1, 3, and 4.
1, 3,
and 4.
and 4. Okay, she has taken the second one out too.
The Chadwick sign.
It's
Chadwick sign is probable.
It's part.
Chadwick is
1, 2, 3, 4.
It's part too.
It's part. Because you, the examiner, the client cannot tell you that. It's you, the examiner, who through your examination that you see that the this thing have a change color. Or is it what is it? A softening? I've forgotten which one is softening.
He was giving us when he was
That's the color.
when he was giving us the presumptive.
Hager is the softening.
4.
Okay.
4.
Okay.
4.
So
One at a time. One at a time, please.
It's okay. It's okay. It's okay. All right.
Okay.
Can I?
Some of us want to talk, so please.
Yes, it's okay. Thank you,
Let's
Madam Mary, the
also
one who read for us.
come in.
So who else want to come in?
I was saying that when he was teaching, he said he listed the presumptive signs. He listed 4.
Okay.
The Chadwick sign, the Hager sign. What's the name of the last one?
Goodell.
The Goodell. I saw, I think, 3 or 4 things you listed under the presumptive signs.
Yeah. Okay.
Yes, that is how I have put it.
Okay.
And then the positive pregnancy, the positive signs, you also give us like 4 or 3 things. Fetal hearts, fetal movement, fetal outline. That is it.
So what will be your final answer here?
So I'm taking 1, 3, and 4.
1, 3, and 4.
Because 2 is presumptive. 5 is a positive sign.
Okay, thank you.
And
Point
6
well made. Let someone else. Tiana. Or Tina, sorry. Tina, kindly meet up and talk for us.
Oh, hello, can you hear me?
Yeah, go ahead, Tina.
The first one, I didn't hear much about it, the ballotment, but I'm assuming it will be 1 because I heard something, but I wasn't sure. But I know that for the probable signs, as you said, it's what the examiner, when the examiner assesses the patient, what he or she sees, that's what will be the probable sign. So we have the uterine enlargement as a result of the fetus growing. Then the positive pregnancy test. That one too, you said is as a result of the CG that will be in the system, but it is not definite unless you use an ultrasound to check. So that one too is the probable sign. And then the Chadwick sign was coloration of the mucous membrane of the cervix, the vaginal wall, and I think the labia. So that one too is a probable sign. So that's what I heard from what you were saying. The
So
others
you are
are
going,
positive signs.
okay. So you
Yes,
are going for 1,
yes.
2, 3, 4.
Yes, yes.
Okay. So yes, I see hands up. Okay, let's
Hey,
reserve it for
please, I want to make a correction.
Go
No, for
ahead.
my choice.
Go ahead with what
Uterine
you
enlargement is a probable sign. Sorry.
okay. All right. Okay, so let's make progress. Okay. I think all those who want to talk touched on all these things. And there are other questions down there. Let's go on with it so that you come in with your answers for the next one. Okay. So we have the final answer being 1, 2, 3, 4. Yes, as she said, it's only the 5 and 6 which are not part of the probable signs. Okay, they are positive signs. Okay, all right. So let's go on. Okay, so we have the 1, 2, 3, 4 being the correct answers here. Right. All right. So the rationale is that I believe we've gone through it. Okay, I wouldn't want to know a lot about that. So we have a pregnant client is seen for a regular prenatal visit and tells the nurse about experiencing irregular contractions. The nurse determines that the client is experiencing Braxton Hicks contractions. On the basis of this finding, which nursing action is appropriate? Contact the primary care provider. Instruct the client to maintain bed rest for the remainder of the pregnancy. Inform the client that these contractions are common and may occur throughout the pregnancy. Call the maternity unit and inform them about the clients that the clients will be admitted in a preterm labor condition. Okay. All right. Whose hand is up? Okay. Madam Mary, your hand is up.
Number 3.
Number 3.
Yes, please. Inform the client that these contractions are common and may occur throughout the pregnancy, because we said they are irregular contractions that occur throughout pregnancy. But they are painless. They are not like that of the true labor contractions.
Okay. All right. That's fine. Points well made. There was another hand that has gone off. I'm sure the person is okay now. Or
Yeah, it was me. I would also go for 3, and then the rationale was what she has also said.
she has
The
also said,
painless irregular contractions. That is
okay.
normal during pregnancy.
Okay. All right. That's fine. All right. So let's move on. No time wasting on this. I believe we all get this. In my initial intro, I did mention of the fact that these contractions are normal to happen during pregnancy. And so when it happens and the woman comes to you as a provider, you only need to reassure the woman and then advise the woman that it is expected. All right. So let's do a calculation here. All right. This is a question on what we went through first, and it was trying to confuse us. A client arrives at the clinic for the first prenatal assessment. The client tells the nurse that the first day of the last normal menstrual period was October 19th, 2023, using the Nagel's rule. Which expected date of delivery would the next plan to document in the client's chart? We have, okay, someone's hand is already up. Madam Naomi. Okay.
I think it's 2,
You
July
think
26,
it's
2024.
okay. All right.
Yeah,
How
this
did
is
you arrive at it?
because, yes. So with me, I use the +3, +7, +1.
+3?
Yeah.
Do you
Sorry,
mean
-3.
-3?
Sorry, -3. Sorry,
Okay.
-3, +7, +1. So the
+1.
-3 means you subtract 3 months from the month you've had. So when I subtract the 3 months behind from the October, I'll go to July.
Okay.
And then +7 means +7 days. So I add 7 days to
Okay.
the 19. Then I would get 26. Then I'll add a year to this my year. Then I'll get to 2024.
Get to 2024.
Yes.
Oh, okay. All right.
Okay.
Is there someone who had a different answer and the person would want to share with us? Or use a different strategy and the person wants to share with us?
Yes, I use
Okay.
the +7 +9.
Okay, so
So
+7.
October is 10th month. If I
Okay.
add 9 to 10, that will be 19. 19 out of 12, 12, I have 7. So that means July is already my month. Then
Okay.
19 + 7 will give me 26. And the ones I've deducted the 12 from it, meaning I will have to add it to the year 2023, making it 2024.
Okay. That's okay. That's perfect. All right. Is there anyone still struggling to understand why we are arriving at the July 26, 2024?
Hey,
All right.
love you never forget.
Hey, these kids, the kids are roaring, All right, so we're having the second one, which is the July 26, like she said, 2024, as our final answer. And we all agree whether you use the counting forward method or you use, okay, someone is asking about February. All right, so whether it is what is it, February 29 for, yeah, it depends on what year you are in, okay, and that's what will tell you. So the rule still stands the same, whether it is a leap year or you are using the 28 or 29 days. If it is February, it is the actual date that will tell you. Okay, so it also applies to February as well. Madam Vero. Okay, so let's look at this. The next is collecting data during an admission assessment of a client who is pregnant with twins. The client has a healthy 5-year-old child who was delivered at 38 weeks and tells the nurse that there is no history of any type of abortion or fetal demise. Using the GTPAL, what would the nurse document in a client's charts? And then the options are there. So let's put our pens together and so that we can develop the data for this woman. Madam Memory. Oh, Memory, is it the man or sorry, I said Madam Memory. Is that your correct name so that I wouldn't memory.
Yes,
Okay.
yes, it's memory.
Okay.
So yes, so we are saying since she's pregnant, we count it as one gravida. Then she is a 5-year-old. So we say gravida, she has 2. So gravida is 2. Then she has a 5-year-old baby who is term. So it's one term. I'll choose B. Then parity.
Okay. Go ahead.
Then preterm. You said P is for preterm. Preterm, she doesn't have a preterm because the 5-year-old did was 38 weeks. So the baby is not a preterm.
Okay.
Then The A is the abortion. She doesn't have any abortion. Then the life,
Okay.
she has one baby who is alive. So it's number 2.
So okay. So memory is giving us number 2. Okay. That based on the information in here, she is arriving at number 2 for her answer.
Number 2 is the answer. I also go for number 2.
Okay. All right. Is there anyone with any other answer apart from what's
Please, someone said number 3 on the chat, in the chat box.
The chat box?
Yes, Mami Doris.
Okay.
So rationale, please.
I'm sure this one is not for that. Mami Doris' answer, I don't think it's for this question. I think it's for the previous question. Well, all the same, if Madame Doris, you are with us and you want to come in with if you think the answer is the third one, I mean you can unmute, okay, and then tell us. I always say this is an adult class, no one knows it, no one knows it all. Okay, we are all learning, okay, from each other. So whatever you have in mind, just bring it on board. Let's look at it together.
Oh no, it's fine. It's 2.
It's 2, eh?
Yes.
Okay.
It was just a typing mistake. Yes, it's 2.
Oh, okay. Okay.
Thank you.
You're welcome. Thank you too. So it's 2. All right. So I think that will be my last question on this then. Let's use the few minutes we have, about 30 minutes or more we have ahead. Let's use it to do something else. So we are moving forward. We are done with my first part for today. And we are going
Please,
into
can I ask a question?
Yeah, you can do.
During the NCLEX, if you type in your answer, can you change it? For instance, she's saying that it's a typing error. And then she realized that, no, I've made a mistake. I want to change it.
What do you say? What do you think?
So why are you laughing?
Sorry. What do you think, madam? In our normal Q banks. Now I want to ask,
No.
I want to bring it to our normal Q banks. Not what I mean on your dashboard, okay? Not what the USRN is on our dashboard. But if you are using UWord, okay, for UWord, sometimes you can even move back. But let's say you are doing assessment, UWord assessment. The moment you press next, you can't go back and change an answer.
Yes.
And the same thing applies to the NCLEX. The moment you press next and you move to the next question, you can't go back again. So that is why before you submit your answer, you need to be confident that, okay, this is what I want to submit. Then you submit it. Okay. Sorry for the laugh. Okay, it's just it's just by this. It's not anything. Don't take that for anything.
Sinamingo.
Yes.
Please, can I have a screenshot of just the last question?
Go ahead, Senior. So you say I should, okay, this is the question.
Yes.
You say you wanted to take a shot or you wanted to ask a question?
Yeah, I needed to take a shot. Thank you.
Okay. All right, let's make progress, okay? All right, thank you all for your submissions and your responses to the questions. I still have 2 hands there. Okay. Annette.
Amigo.
Yeah, Madam Annette.
Yeah, I think I just saw someone's question and I think I just want to respond to that. Someone who was asking whether you can take a calculator along.
Calculator.
Oh,
no.
But I just want to say that I think there's a calculator on the dashboard
On the screen,
when you are answering.
yes.
Yes, on the screen. So you don't need to take a calculator along.
Yes. Like the way you are doing your UOD and then you open and there is a calculator on the screen. Is it the same thing that applies to the NCLEX? I think all the various Q banks, they have that calculator inbuilt in their system. So you don't take calculator along. Okay.
Please, I want to find out something. Hey, I was doing some Q bank and they select like that highlighting thing. I was doing, but I didn't know how to do it.
Okay, so you were answering a case study, or sorry.
I was using my phone, so when I tap the yellow, this thing can bet. Immediately, I move my hand and go to the next. It clears.
And so it could be it's from maybe the device you are using, or the problem is from the Q bank. That could be the meaning. It's either the device you are using or the problem is from.
Or is it
Okay.
that I'm not doing it?
So I think, like I said, the problem could be from the system, the Q bank you are, or it could be as a result of the device you are using. Okay, that could be the problem.
Okay.
So next time you try to use a different device and see if the problem still persists. It could be from the device. Okay, let's go on. Okay.
I've never actually done it. So I just use my phone and I didn't know whether I was wrong or.
Okay. So let's make progress. Okay, let's mute up. Okay, so that we have a common class. Okay, let's mute up. Okay, let's go into this. So we are moving on and we want to determine the fundamental height. Okay, so we are now going to go into the various prenatal assessments, the prenatal labs that you have to do for the woman, and then how long the woman would need to even be coming to the hospital for assessment until the woman delivers. So we'll go through it very swiftly. This time it's not on our side. And so when it comes to the determining of fundamental height, house, kindly mute out for us. Okay, I get a lot of people, a lot of feedback, and that is
Please,
how.
why is the co-host? The co-host should mute them. Who is the co-host?
I'll remove you all. If I remove you, you
co-host?
can't join. It's okay. It's okay. It's okay. If I remove you, you can't join the class unless next week. Okay. If I remove you, you lose today's class. I mean, the reminder of the class, you might lose it unless next week. Okay. So I've muted them. Let's go on. So we are looking at where to locate the fundamental height at what gestation. And then for this, I have simplified in terms of the weeks and then where to find the fundamental height. And that is where they mostly ask. So for instance, they will ask you at around 16 weeks of gestation, where should you locate the fundamental height? At 36 weeks of gestation, where should the fundamental height be located? Or the fundus, sorry, where should the fundus be located? And then between 20 to 22 weeks, where should the fundus be located? Now, the purpose of you knowing this is that if a woman presents to you and then at a certain week of gestation and the fundamental height is at a certain level, knowing this, you can determine as to whether there is any fetal growth restriction or there is anything happening to the woman, especially if the fundus is more than what is expected. It will help you to educate the woman, to help you to even go ahead and do further assessment so that you know that this level at 16 weeks of gestation, you don't expect the fundus to be at the umbilicus. At 16th week, the fundus shouldn't be at the umbilicus. So if a woman comes to you at around 16th week and then the fundus is at the umbilicus, it calls for, a concern. You have to refer the client to the healthcare provider. At the same thing, if at around 12th week of gestation, a woman comes to you and the fundus is between the symphysis pubis and the umbilicus, it should also ring a bell in your mind that something is also wrong, so that probably further, referral processes or assessment would have to be made. So that is the purpose of we knowing this. And if you want to assess someone's fundamental height, we all know that you can use the fundamental height to equate, or you can equate the fundal height to that of the the week of gestation, or the gestation week, or you can use it to evaluate the gestational week. Okay, and you can only do that, I mean, from 18 weeks to 20 weeks. That is between 18 to 30 weeks. That is when you can use a tape measure, and we know that we use tape measure to do this measurement. And so during that time, you use the tape measure, you measure the fundus. When you measure the fundus, that becomes your fundal height. Now, the principle is that you can get either plus or minus 2. Plus or minus 2 in centimeters means that when you use your tape measure to measure the fundus, the value that you get, okay, you can use it to evaluate the gestational week, and that can either be plus or minus 2 of the week of gestation the woman find herself inside. So that means that, let's say, if you measure and then you get let's say 18 centimeters, you can use that to determine that the woman is in her 18th week of gestation. It can either be 20 or it can be 16. So if it is 20, it means that it is plus 2. And if it is 16, it means that it is also minus 2. Either ways, you are correct. That is why it is an estimation. You are not going to use it to finalize that this is the week of it only gives you an estimation of what, I mean, the expected gestational week of the woman is. So to measure this, we say that you have to make sure that the bladder is empty, because if the bladder is full, the bladder also will kind of, I mean, push the fundus, or it will push the uterus a bit higher, and that might give you a wrong figure. So if you want to determine someone's fundal height using the tape measure, you have to make sure that the client's, I mean, bladder is empty. As you ask the client to empty the bladder before you use the tape measure to determine the fundal height. My interest here is where to locate the fundus at 16 weeks of gestation. And so at 16 weeks of gestation, you should be able to locate the fundus between the symphysis pubis and the umbilicus. For this one, we all need to keep this in our minds, okay, or keep it in our pockets, so that when we are reading our questions and we come across this, we can easily pick it up and then produce the answer. So that is why I've classified it into these three. That at 16 weeks, because that is where mostly the questions is around these weeks. So at 16 weeks, your fundus should be between the symphysis pubis and then the umbilicus. Then at 20 to 22 weeks, your fundus, or the fundus of the pregnant woman, should be approximately located at the umbilicus. And so it says that the fundus is approximately at the location of the umbilicus. That is between 20 to 22 weeks. Then at 36 weeks of gestation, the fundus should be at the xiphoid process. At the xiphoid process, because at that time, you expect the uterus to would have enlarged enough because of the growing fetus. And so you see what we call the fundus to be at the xiphoid process. And then after 37 weeks, or after 36 weeks, you see it dropping again because of, I mean, the person probably moving into term gestation, and then any moment from there, labor could set in. And so these are the three areas I want all of us to keep it in our mind, where to locate the fundus, or at what week of gestation you should locate the fundus. Then I made mention that in order to use the tape measure to measure someone's fundal height, or a pregnant woman's fundal height, you must make sure that they have an empty bladder before you do this, in order not to get any abnormal figure, especially if the bladder is full, okay, because it can have effect, or it can display the uterus, and that could also influence the figure that you're going to get. let's quickly go through this discomforts of pregnancy and some of the things you do for the woman. Now, I made mention that nausea, vomiting, it's normal in the first and usually subside by the 3rd month. It occurs in the first trimester, and then by the time the woman moves into the 2nd trimester, the issue of nausea and vomiting might have subsided. That is the reason why, if it still continues or it persists, then you know that, the woman is now having an issue and you need to attend to the woman. The issue has to do with the fact that the problem is, or the nausea and vomiting is because of hormonal changes, the HCG that mostly gets elevated, and then other hormones, and then carbohydrates metabolism. And so if there is any change in carbohydrate metabolism, it also leads to this form of discomfort. One of the teaching that you give to a woman who is experiencing nausea and vomiting in pregnancy, especially during the first trimester, is that they must make sure that they are eating dry crackers before they arise from bed. They have to avoid brushing their teeth early or the first thing. Brushing their teeth shouldn't be the first thing in the morning, okay? Because when they do that, it can, cause them to experience the nausea, vomiting. Hey, who is writing on my screen? Then they will also have to eat small frequent meal. And I always say that eating small frequent meal for any condition in NCLEX is the correct answer you should choose from if it has to do with diet and how a client has to eat. And you have eating small frequent meal. That is the best answer the person has to, you should choose, or best education you should give to a patient. Okay, because here, if the patient eats and then the abdomen becomes full, it makes the person to feel the urge to vomit if the abdomen becomes completely full. So that is the reason why you need to tell the person to eat more frequent. They will need to avoid drinking water with meal or drinking fluids with meal, but rather one has to drink fluid in between meals. So in between meals means that when you eat, you have to wait for some time before you take in the water, or to prevent the person from having a full abdomen. Then you also have to make sure that they are avoiding the intake of spicy foods. They will have to take in protein snacks at bedtime. Then they suck on hard candies. Because of the nausea, vomiting, sucking on hard candies could also help them. And then even in some books, they'll tell you if you're having dry mouth and those things, you also take hard candies as well. You have to, talk to the healthcare provider about the use of other alternate medicines. So if the client comes to you that I have some local preparation I want to go and use, you have to make sure that before the go ahead is given, the healthcare provider is made aware of it, or you refer the patient or the woman to the healthcare provider for the healthcare provider to give a go ahead on it before the woman can use. Then any herbal medicine, then taking of antiemetics. So I think for the purpose of the NCLEX, one of the antiemetics that you come across is ondansetron. So ondansetron is one of the common antiemetic medication you come across it. The next thing you also have to understand is, syncope. If a woman comes to you that they are experiencing syncope, what are some of the things that could lead to the syncope, and what would be your education as a nurse or as a healthcare provider to the woman? And we should know that the syncope feeling or the dizziness that the woman will feel mostly has to do with what we call supine hypotension, or hypotension that mostly causes it. Another thing that can also cause it can be with, let's say, anemia. Okay, we all know that, during pregnancy, most women tend to have what we call anemia. It could be as a result of increase in the blood volume. Then you could also have what we call position change. So let me talk a bit on what we call supine hypotension. What happens in pregnancy is that during pregnancy, the weight of the uterus exerts a bit pressure on the inferior vena cava. And when that happens, it also affects venous return. And when venous return is affected, it leads to what we call hypotension. Then when there is hypotension, we know that it comes with what we call dizziness, and then the person can go into what we call syncope or fainting. So these are some of it. So one of the things you have to do when someone is pregnant, that's the reason why we always encourage a pregnant woman to assume a left lateral position, because if they lie on supine position, that is where you have the uterus exerting the pressure on the inferior vena cava. But when the woman lies on the left lateral, it's that kind of pressure that has to exert will not be there. And so that is why it also promotes what you call venous return if the woman lies on the left lateral position. So when it comes to your intervention for syncope, because of venous return, you have to make sure that when the woman sits down, they have to elevate their feet so that venous return can be improved, or blood returns can be improved, and then the issue of what we call hypotension will reduce. Then you also talk about the fact that because the woman is experiencing syncope, we have to institute 4 precautions. So we have to make sure that the woman is nursed on what? On the low bed. We have to make sure that there is a bit, adequate light in the room, so that the woman will see when they are to wake up and all that. And if they have to change position, they will need to make sure that they do that change of position slowly, because if they change position abruptly, what will happen is that they are going to have what we call the supine hypotension, or there's going to be a drop in their blood pressure, and that is going to lead to what we call the dizziness, and then the syncope also happening. Then you encourage them to lie on their left side, so left lateral position, which is the best position for a pregnant woman. Then we also talk about urinary frequency. So in urinary frequency, you have to make sure that you understand that the first and third trimester, that is where you expect urinary frequency. Second trimester, it is not normal for urinary frequency to occur. So if it occurs in the second trimester, like I said initially, it could be as a result of UTI. So the healthcare provider will need to do urinalysis to determine what is the cause of the urinary frequency in the second trimester. Third trimester, hormonal changes. Sorry, first trimester, hormonal changes. Third trimester, urinary frequency occurs because of the weight of the uterus on the bladder. Then the education or the interventions are adequate fluid intake, unless there's any other condition that is causing the woman not to, or any other underlying condition that will prevent the woman not to take about 2 liters of water a day. For a normal person, at least you should take about 2 to 3 liters of water every day. Then you limit the intake of water in the evening. Yes, I got a feedback. Was it a question or someone wanted to come? So let me go on. Then in the evening, the reason why you have to limit the intake of water in the evening is that you don't want to cause the woman to wake up during the night to be urinating. Okay. That will disrupt the sleeping pattern of the individual. So you have to limit the intake of water in the evening. The client has to avoid any form of natural diuretics like caffeine, okay, like tea, watermelon, and then lemon. All these things can cause an individual to urinate a lot. So you need to avoid this natural diuretics. Then avoiding what we call voiding at regular intervals. Okay. Then they sleep on their sleeping sidelining at night, wearing perineal pad, that is to help with the care of the perineal area. Then Kegel exercise. Okay. For our women here, I think most of you understand what the Kegel or how the Kegel exercise is. Last time some people were teaching me how it was done, but I think they have some big ball that the person would have to think, just sit on it or something like that. Then it will help. So the purpose of it is that it will help the pelvic floor. Okay, it will help strengthen the pelvic floor so that it will be able to contain what we call the bladder, and that would also help to reduce the frequency of the urination the person will be experiencing. Breast tenderness is very important that we all need to understand that throughout from first trimester to the third trimester, there will be some form of breast changes, just to prepare the woman for breastfeeding, breast milk production, and all that. Hormonal changes playing key role here. Interventions are that the woman will need to wear some form of supportive bra. Then one key thing I want you to take from here is my last point, where I'm saying that you do not use soap. Do not use soap to wash the nipple or to wash the breast. If the woman complains of having some form of breast tenderness, and then they are telling you that they are going to use soap to wash the breast, it is contraindicated. The reason is that if you use the soap, because the soap is made up of chemicals, the chemicals can cause, or the use of the soap can cause some form of cracks on the nipple. And when these cracks happen, the skin integrity has been affected. And so the issue of infection is also a concern here. So the reason why a woman is not allowed to use soap on the nipple and that of the areolar area, just to prevent the area from drying and cracking up. So if the woman has to wash the breast, they will need to use just a lukewarm water to wash the area, and then they dry it out. That is all. No soap. Whether they make mention of mild soap or whatever soap they make mention of, know that soap is not allowed to be used to wash the breast or the nipple. Let me put that one. Now let's go to, do we still have time? Okay, let's do this antepartum screening. Okay, by the way, if you have any question or any input you want to make on some of the things I've talked about so far, you can bring it on board as well. Yeah. All right, so let's do this antepartum screening or diagnostic testings in pregnancy. I'm sure we'll not be able to finish up with this. So next time when we meet, we'll finish up. I wanted us to finish this part, then next week we can make a progress. But let's go on wherever our time ends. We come again, and then we continue from there. Now, let's go into the various antepartum diagnostic testings, okay? And these are standard things that are done in the US. Okay, remember that all that we are making mention of, or all that I'm talking about, we are learning it for the purpose of the NCLEX. And then, of course, to go and practice it there. And then if you learn it here and then you are still in Ghana, you can still make use of it here. But don't think that what you do in Ghana here is what you're going to do in the US. Now we are learning English, so we have to bring the NCLEX standard to our work areas in Ghana here. Okay. And all these things are standard testings that are done for every pregnant woman in the US. So what we need to know for the first part is that we need to understand that antepartum visits is done every 4 weeks for the first 28 to 32 weeks. If a woman is pregnant, I think that one, so I've seen questions on it. What is the consistency, or how consistent should a woman be coming to the hospital for, checkup? And so for a pregnant woman, the woman will need to visit the healthcare provider, will need to come for, her regular checkup for the first 28 to 32 weeks. The woman should come every 4 weeks. Every 4 weeks, the woman would need to come for the first 28 to 32 weeks. Now, from 32 to 36 weeks, the woman will need to come every 2 weeks. So between 32 to 36 weeks, the woman will need to come every 2 weeks. Then from there, every 1 week. So from 32 weeks, from 36 weeks, it means that the woman has moved into the 37 going, which is a term gestation. And anytime from there, the woman can go into labor. That is why the woman is scheduled to come every 1 week from 36 going. So 36 to 40 weeks, the woman has to come every 1 week. And then from 40, we know that that is post-term. And then probably admission will have to be made, and then from there, other things will have to, but these are the standard schedule for someone who is pregnant. Yes, Madam Augustina.
Hello.
Yeah,
So
Madam
if
Augustina.
I want to understand you well, in US, ANC or antepartum this thing, they said it started from 28 weeks of gestation.
It starts from, I say it starts from 28 weeks.
Yeah. So
No,
what you are saying.
no, that is not what it means.
Oh, okay.
What this means is that, you know, when someone is pregnant, okay, I mean, it has to take some few weeks before the person starts ANC, okay. So we are saying that you can even forgo of the 28 weeks, okay, and then stick with 32 weeks. From 32 weeks coming downwards, the woman has to visit the hospital or has to go for review every 4 weeks. Or the woman goes to, check up every 4 weeks until 32 weeks. Then from 32 weeks to 36 weeks, the woman has to go every 2 weeks. Then from 36 to 40, the woman has to go every week.
Okay. All understood.
That makes sense, eh?
So,
Yeah.
hello.
Yes,
Hello.
madam.
So if I get you right, meaning that from the beginning of pregnancy to 32 weeks, the client is going for 4 weeks. But immediately you enter to 32 weeks, you go for 2 weeks 2 times. Then
Yeah,
you
sure.
now that will give you the 36 weeks. Then when you are 36, you also go for 1 week for 4 times before you deliver. That's
Yeah,
how I understand.
yeah. If that is how you also understand this, that is fine. So she has been able to classify the number of times the woman would have to visit. Okay. That, let's say between 36 to 40, that is 4 weeks. So the woman would have to go every week, and that would be 4 times. And between 32 to 36, that is also 4 weeks. However, the woman will be going every 2 weeks, so that will be 2 times. And then she also gave the breakdown from, the moment the client starts up to 32. So it depends on when the woman first started her antenatal. And so let's say the woman started her first antenatal at 13 weeks of gestation. Okay. Let's say the woman started her first ANC visit at 13 weeks of gestation. Then they ask you what will be her next visit. So you know that because the woman is less than 32 weeks, the woman would have to go for visits in the next 4 weeks. So you add 4 to the 13, you get 17 weeks. So that is the essence of we learning this. All right, there's a hand up. Let me go to those whose hands are up from Madam Vivian.
Hello.
Yeah, Madam Vivian.
Okay, I just want to ask one. I think it's almost the same like here, Ghana, where I work. They go for 4 weeks up to 30 weeks, and then from 30 weeks, 2 weekly, then 36 weeks is weekly. So I think the only difference is they are starting the 2 weeks from 32 weeks.
32
Here,
weeks, yeah.
where I work is 30 weeks, we
Okay.
start 2 weeks. Thank
Okay.
you.
Okay, thank you for that. Is there any other one with an input, an addition, subtraction? Right. Okay. So you have to know. I think one question I saw is just the scenario I gave. They give you the week the woman came for the visit, like 13 weeks, and they ask you what would be or when should the woman come for the visit again. Then if you know that 13 weeks, the woman from there to 32, the woman would have to come every 4 weeks. So you add 4 weeks to the 13, you get 17. So the woman would have to come for her next visit on the 17th week of gestation. All right. So that is on the scheduling for antepartum visit. Yeah, memory.
So I wanted to ask, where I was reading, I read like first Up to 20 weeks, that's when the women can come for like 4 weeks. So which one should I choose? Is it 20 weeks or up to 32 weeks?
I struggle to get your question. I don't know if anyone.
Okay, from where I'm saying the doctor's monthly visit, I read it up to 20 weeks for like the first for up to 20 weeks, the patient will be going monthly visit.
Yeah.
But you said it can be 20 up to 32 weeks. So I'm asking which one should I choose? Like if it comes in the exam. I don't know if
Okay,
you're getting it.
let me throw the question to the whole house so that someone can. I'm struggling to get memory. Okay.
Because you said bi-weekly it's saying, for me, what I read is it's saying 20 to 36 weeks. But you said bi-weekly, what did you say? You said 32 to 36 weeks, right? So I think only the error is on the monthly thing. I just want to confirm which one should I use, up to 28 weeks or up to 32 weeks?
Okay. Let's use the 32 weeks. Okay, sorry. I think I got it. 32 weeks. Okay, 32.
All right, thank you.
32 weeks. Sorry, I was struggling to get you. And there was some breaks in the network. I was struggling to get you.
Okay, fine.
All right. Let's do this. I know our time is up, but borrow me just about 5 minutes of your time. So let's do this and then we drop it here for today. So the next thing we looked at is what are the schedules for giving of your ROGAM? Okay. So when it comes to ROGAM, you need to understand the schedules and when to give ROGAM and when not to give ROGAM. And this, like I said, this is a standard practice in the US that if a woman is pregnant, okay, on your first visit, okay, they will need to do all this testing. So they will have to determine your resource factor. And if your resource factor comes out to be what we call negative, okay, if the resource factor comes out to be negative, or if they do the test, whatever the results is, the healthcare provider would have to wait until 28 weeks of gestation. When it is 28 weeks of gestation, they would have to do the test again, or they would have to screen you again. Now, when you are screened, and then it is noted that your resource factor is what we call negative, the healthcare provider will give you the ROGAM at 28 weeks of gestation. Then, when it is positive, I mean, you are good to go. No need for ROGAM. Then when you deliver, okay, when it is negative, they give her 28 weeks of gestation. Then when you deliver, between the first 72 hours, a repeated dose will have to be given if the test is done on the baby and then the baby is having a resource factor to be positive. So in that instance, the mother and the baby had different resource factors. So I'm saying that when the test is done at 28 weeks, so let's say at 28 weeks, if it is done and then the woman is negative, they would have to give the woman a ROGAM. Now, after delivery, okay, we have what we call comb test, direct comb test. So we have indirect comb test and direct comb test. The indirect comb test is what is done on the mother to determine the mother's status. Because at that point in time, around 28 weeks, you can't pick the fetus sample. You can do through amniocentesis, but because of the risk factors and other things it comes with it, the healthcare provider will not do it. So they would have to wait until the baby is born. And when the baby is born, another test would have to be done, which is a direct comb test. And so this direct comb test is done directly on the baby to determine the baby's status. So if the baby is having a positive and the mother is having a negative, that means that another dose would have to be given to the mother to prevent what we call is it oh I've forgotten the term. Would have to be given.
Thrombosis fetalis.
Okay, repeat it again for me. Mr.
Erythroblastosis fetalis. All right.
What fetalis? All right. So I just want you to understand the schedule and how you give it. But if the test is done on the baby and the baby is also having negative, there wouldn't be any need for you to give it again. So you repeat the dose again after delivery between the first, so you have between the first 72 hours to do this. You do the test on the baby. If the baby has a positive result and the mother was having negative, you have to give the dose again. If the baby had positive and the mother was the baby had negative and the mother was having negative around the 28 weeks where the first dose was given, no need to give the dose again. Now, it is not only during that instance where you have to give ROGAM. If the mother has a rhesus negative factor to be negative, and there is any form of miscarriage, any form of abnormal bleeding from the woman will need to take ROGAM again. So, for instance, if there is miscarriage or there is abortion, and the woman is known to have a rhesus factor of negative, a dose of the ROGAM will have to be given. If there is any form of abdominal trauma or there is any form of RT, and then it results in any form of vaginal discharge, which could probably be coming from, you cannot determine where the discharge probably might even be coming from. But so far as there's been that form of, pressure on the abdomen through the trauma or through the RT, and then the woman is bleeding, they would have to give the woman a dose of the ROGAM, because you might not know that there is a missing of the maternal and the fetal, blood. So these are how you go about your giving of your ROGAM. The purpose of the NCLEX, this is how best I can explain it for you to understand. If you also have a way you also go about it to understand it, you can also bring it on board. I see Madam Mary's hand out. Yeah, Madam Mary, you can come in.
I want to find out something. The organ given during pregnancy, please, is it done in Ghana here? Because I only know of it after delivery. I want to know whether we are doing.
Yes, it's done. Oh, yeah, it's done.
It's
done.
done.
It's done. Yeah, it's done. It's done. Yeah, it's done.
Okay, thank you.
So I think in Ghana they call it anti-D.
Anti-D, okay. Yeah, it's done. It's done. But I know it's very expensive, none of the kids.
Yes, it's very expensive.
Around 1,000 cities or so. So you know how, especially if you are in a rural area and then you have to tell someone to prepare for 1,000 cities for 2 doses. First around 28, and then when they deliver, you have to also make preparation for it. You know how it is. So they give. Madam Ellen, your hand is up.
Yes, sir. I know time is about just clarification. So the test, how is it done? Is it the same resource that is with your blood group, or is this a different thing you're talking about?
Yeah, it's the same. Yes, blood group, yeah.
So we check your blood group, and let's say you are O positive. Are they going to do something with the baby to know what the baby's type is before you are given?
That is why I said that.
Before delivery.
No, so that is why I said that it is basically done on the mother, even though samples can be taken from the fetus, but that has its own what we call side effects, especially with amniocentesis. Okay, and so it is not mostly done whilst the fetus is in is still in the uterus. Until the baby is done, that is when you can determine the status of the baby.
Okay, so sorry. So are you saying those who go like anyone with a rhesus negative blood type is going to have a ROGAM at 28 weeks of gestation?
Yes, that should be the ideal.
Oh, wow. Okay, thank you.
Okay, we have our midwife. So, Madam Sandra, your hand is up.
Hi.
Hello.
I just wanted to say I just wanted to share my experience because I'm O negative and my husband is B positive. So when I got pregnant the first time, around 12 weeks, I had a miscarriage. So they gave me an injection. That's the ROGAM. They still call it ROGAM in Ghana. So I just wanted to share it. And then the midwife who was meant to give me the medication, she wasn't familiar with it, so she just turned the medication upside down, trying to like understand the meaning of it, and everything dropped up, like it just fell. And it was so expensive. And then we were both angry, and then the whole team was angry at us, and then we were also angry. And instead of them to apologize, to spend almost 1,000 cedis. And then instead of them to apologize, I mean, you've gone through a traumatic situation. And for somebody to give you like a medication that you had to buy and it was so expensive, and then due to their own negligence, like you have to buy another one. They didn't even apologize and they were angry. So we had to buy another medication. So actually didn't let them administer it for me. So I went to look for my friend midwife who like I think they give it often and then she administered it for me. So yeah. So now I've got a daughter. So anytime I give birth, they give me that ROGAM. So at 27 weeks, between 27 28 weeks, they give me the ROGAM. And then after my baby is born, within 72 hours. Mine was 24 hours, and then they'll give it to you.
We apologize on their behalf, okay?
on that very midwife, on that.
We will not take it. We will not take it.
I know, right?
In fact, we apologize on
We
their
apologize
behalf.
for her. Okay, it won't happen again. Sorry for that.
Thank you, guys. Yeah.
Thank you for yours. Thank you for that, Madam Annette. Yes, Annette. Let Annette talk. Annette has been up.
Oh, okay.
Annette.
Okay. Yeah, thank you. So please, I have met this question several times. I want to be clear with it. So it means that at 28 weeks, when you test the woman and the woman is positive, the woman is good to go.
Yes, it's positive, it's good to go, yeah.
Yeah, but when it's negative, it means at that 28 weeks, you need to give ROGAM to the mother.
Yes.
And then after the delivery of the baby, after 72 hours, when you can carry the test on the baby, but not the mother.
I say after 72 hours.
Yes.
Okay,
you check the mother or the baby?
So the practice is that you should do the test within 72 hours.
Yes, within 72 hours.
That you should do the test. You should do the test on the baby.
Normally 24 hours. Okay.
So
within 72 hours, you do the test on the baby.
Yes, to determine the baby status as well too.
Yes. So when baby is positive,
you give the dose again.
To the mother or the baby?
The mother. Of course, the mother the problem is likely going to continue.
But when the baby is negative?
Yes, that means that no problem. You don't repeat the dose again.
You will not repeat the ROGAM again?
Yes.
Okay. Thank you very much.
You're welcome. Tina.
Okay, Mr.
Hello.
Yeah, let Tina come in. Tina, I'm calling those whose hands are up. So if you want to come in, make sure your hand is up.
Hello.
I just want to say that.
Hello. Hello, can you hear me?
Yeah, Tina, go ahead.
Oh, sorry.
Tina, kindly go ahead.
Okay, I wanted to find out. So after, let's say, a woman has the first pregnancy, is tested and is RH negative. And then after delivery, we give the ROGAM at 28 weeks. Then after delivery, within 72 hours. With the second pregnancy, if it repeats itself, are you still going to repeat the same thing? Or the first pregnancy takes care of the subsequent pregnancies?
You continue. You still give it
You
for the
continue.
subsequent
So I
pregnancy.
think for the subsequent pregnancies. Okay. All right. Thank you.
Yes, I fear.
Oh, I just wanted to say that I'm a B negative. And then all my pregnancies, I was given the program.
Oh, okay.
So I knew about it. So when I get there, I just inform them I'm B negative.
Okay.
Yeah.
Okay. Is there anyone else? Sandra, your hand is still up. Do you still have something to say? Or is that an old hand?
Oh, sorry. I don't know.
Okay.
Sorry.
Okay. Thank you. So it's been an insightful class. We've all shared our experience from books and then even from practice. So that is good. It helps us all to understand. I think if in the absence of Mary, your hand is up again.
Please, I want to share some story. One pregnant woman, she was negative, and in the first pregnancy, she didn't buy the Rogan, and she delivered successfully without any problem. So the second one she's having, we asked her to buy. She said, "Oh, she will not buy because the last one they said she buy, she didn't buy. Nothing have happened to her. They said she can't get pregnant, but now she's pregnant. I don't know whether was it that the child was also a negative risk.
Was the test done on the baby?
No, some of these people they will
Yeah.
not be able to
So
match
yeah.
her, but
So it could,
probably the child was a negative
yeah.
blood. That's why
Yeah.
she didn't develop. Oh,
Yeah.
okay.
Yeah. It could be that the baby also had a negative. That could have been the factor.
Okay.
Hey, I'm not hearing.
You didn't hear.
So she was saying that she was given an experience where she's saying that she had an experience where someone came with a negative results factor. They asked the woman to buy the program. She didn't buy even at 28, and then after she delivered, she didn't buy. And then according to her, the woman said nothing happened to her. And so her subsequent pregnancy, when they asked her to buy, she said that since the first one, nothing happened to her, she won't buy again. So she won't buy any medication again. That's what she. So she was saying that it could have been that for the first one, the baby results factor could have been the same as that of the mother. That is probably maybe why the mother didn't experience any problem.
Okay. Okay, thank you.
All right. Madam Ellen, your hand is up
Yeah,
again.
sorry, sir. I'm taking back a bit with the gestational age.
Okay.
When you're using the fundal height. So if
Okay.
you said, I don't know if I got it right, but you said the number of weeks equals to the fundal height. Can you use the number of weeks to estimate the fundal height?
You rather use the fundal height to estimate the number of weeks of gestation.
Okay. So does it? And I think I had something +2 or -2 or something.
Yeah. So I was saying that when you measure, let's say you use your tape measure, you measure the fundal height, and you are getting, let's say, 30. Okay. What it means is that 30 centimeters. You can use it to say that, or you can estimate it to the week of gestation to be 30, but that is not that is an estimation. And in estimation, we assume that it could be either +2. So in +2 could be that the woman is either 32 weeks or -2. That means that the woman will be 28 weeks. But when you are writing, you write the 30 weeks. But you should have it in mind that it could either be plus or -2.
Okay. Can you use for any number of weeks or certain like
You can
25
use
weeks?
it from 18 weeks going. That is when you can use the fundal
So
height to
25 is fine.
determine.
Okay.
Yeah, to determine
All
from
right.
18 weeks going. Yeah.
18 to okay. Thank you, sir.
All right. Who else? Derek.
Amigo.
Yeah, Mr. Derek.
I wanted to know if maybe after 28 weeks and the woman is positive and they gave him the first dose, and maybe probably after delivery within
negative.
70.
Positive,
Yeah.
will not be negative.
Sorry, negative. And maybe probably after delivery within 72 hours, she couldn't afford it, and maybe over 72 hours, and the woman is not feeling well, like, and they want to give it after 72 hours, can they give it or something like that?
Where you can give, might not give the, after 72 hours, the probability that the woman would develop the, I mean, oh, I forgot the condition. Erythroblastosis fetalis, very good. The woman would develop erythroblastosis fetalis after 72 hours is very high.
Oh, okay.
That is why it has to be given within that time duration. You can give it, but after 72 hours, you might not get the needed effects you want.
Oh,
By then,
okay.
the woman might have been, I mean, in trouble already.
Oh, okay. Thank you.
Okay. More hands, Nanakia.
Yes, sir, please. You see, some people, they are obese, and others too, naturally, they are not fat. So when you measure their fundal height, are you going to get the same thing?
Oh, you still get for them. Our midwives are here. I think you still get the same thing.
Oh, okay.
You still get. So whether the person is obese or not, we still use the tape measure, okay? And you get your
Mr. Mingo, we have eaten it into our time match.
You see, a lot of questions. I think I have to drop it here. If I don't drop it there, okay, Madam Vivian, last question. Madam Vivian.
The class is interesting.
I just want to say that whether obese or not obese, the best thing is you should be able to locate the fundus.
The fundus, very good.
If you are able to locate it, if the person is obese or not obese, is the same. Thank you.
The same. Okay, thank you for that. I think at this point we all agree that we should drop the class here for today. Done about 30 minutes into our closing time. All right. Thank you all for staying with me. Thank you for bringing your contributions and then your and your responses. It's been insightful. So we'll end it here for today. And then we meet again next week, Saturday. We'll go through again and then we'll see what we can do. May God help us all, give us an understanding of everything we've been learning so that we'll all get our license at the end of the day. Amen.